Mike Gibson, Usman Baber, coming to you live from SCAI 2017. Usman, you've now presented some of the data from BRAVO-3. Let's talk about atrial fibrillation in the patient with TAVR and the optimal management strategy. Tell us a little bit about BRAVO-3.
Absolutely, Dr. Gibson. It's a pleasure to be here. So the paper that we presented earlier was a post-hoc analysis from the BRAVO-3 randomized trial. This was a trial led by Dr. Dangus. It was a trial of high-risk transfemoral TAVR patients. 802 patients were enrolled. These were centers in Europe and in North America. And the salient question of the BRAVO trial was whether or not a periprocedural anticoagulation with bivalirudin would be superior to standard unfractionated heparin. Again, these were high-risk patients. This was all transfemoral. The primary results of the BRAVO trial, which were presented and have been published, were negative for the primary endpoint of major bleeding at 48 hours, so no advantage to bival compared with heparin at 30 days major bleeding. And the second co-primary endpoint was NACE, MI, death, stroke, or major bleeding, and there was no advantage to that as well. So that was the overall primary results of the BRAVO-3 trial, and in this paper, what we wanted to do is dive a little bit deeper into the data and get some more insight into the patients who had atrial fibrillation in the BRAVO-3 trial, understand their profile, understand the risk after AF, and whether or not bivalirudin would yield some differential outcomes in those patients. And to your question about antithrombotic strategy, I think that is sort of a great question because it's an evidence-free zone, and I don't have to tell you who's done so much work in this space, but certainly what we examined, and one of the key insights that we found that we thought was quite interesting, in the about 330 patients who had atrial fibrillation in our analysis, the vast majority of them met classical criteria for anticoagulation. The vast majority of them had CHA2DS2 VAS scores of at least 2, which by evidence-based guidelines is a requirement for anticoagulation. Nevertheless, when we examine how physicians were treating them, and this was not prescribed by the protocol,
right.
Clinicians were free to do what they wanted, 30% actually went home on DAPT, no anticoagulation.
Do you know why, I mean, with the CHA2DS2 VAS score of 2, why people went home with DAPT?
So I think some of the earlier work that we and others have done to try to explore the decision-making apparatus at this time point, I think boils down to perhaps two things. Number one is certainly the concordance between thrombotic and bleeding risk. So you have a convergence, an overlap, and so a lot of your high thrombotic risk patients by the CHA2DS2 algorithm are also going to be at high bleeding risk. That then makes decision-making difficult, and I think by default clinicians will tend to avoid prescription of therapies that might yield harm, even if it means potentially depriving patients with benefit. I don't have proof of that, but that's my speculation.
So do no harm, is this asymmetric warfare between do no harm and risk-benefit?
Completely agree.
Yeah,
completely agree.
But then on the other hand, 60-some% were on anticoagulants.
You're absolutely right.
And what were those? How did they?
It was really interesting. So
the drugs?
again, we just collected this, and what we found is, yes, about 60-some-odd, 63, 64% did go home on an anticoagulant. The most common combination was an anticoagulant with aspirin alone. Second most common, about 20%, was a P2Y12 inhibitor with anticoagulant alone, so using sort of the single strategy of antiplatelet with one anticoagulant, and a minority, about 10 or 11%, did go home on triple therapy. So clearly clinicians are making their own decisions with respect to the potency of the antiplatelet agent and the anticoagulant if they deem the patient can withstand an anticoagulant.
You know, the slide I always show, Usman, is the 2.2 million permutations. And as I always say, we will do all 2.2 million permutations in clinical practice.
Yes, completely agree.
Interesting. And did AFib confirm more risk in these people?
Yes, and you know, there are several studies to date from partner data and other registries that have shown increased risk with AF. Our results were largely consistent with that. Now, about 40% of the patients in the BRAVO-3 trial did have atrial fibrillation. This is either AFib at the time of TAVR, and a smaller number, about 5%, developed AFib after TAVR. So we combined both of those groups into one AF group. We did find numerically higher rates of adverse events. Now, we did not get statistical significance. I think that's kind of missing the forest from the trees. That's just an issue of small numbers. And when we looked specifically at the patients who had new onset AF, that small group of patients, they were at profoundly higher risk, fourfold higher risk actually for adverse outcomes, including stroke compared to their counterparts without AF. Again, that has been highlighted by several other investigators, so I think points to the real morbid profile of those patients. And one of the, I think, interesting questions is whether or not that's causal. whether or not the new onset AF is causally related to the excess risk, or is this simply a marker that has to do with procedural or other hemodynamics?
Or LV dysfunction
Or
causing
LV
LA
dysfunction.
stretch, causing AFib.
Exactly.
Yeah, which is kind of what we saw in the STEMI setting. AFib patients always had worse outcomes, probably as a reflector of new onset heart failure.
Right.
Yeah. All right, well, we learned a lot here in BRAVO-3. Congratulations.
Absolutely.
And
Thank
look
you.
forward to more lessons from that study. Thanks, Usman, for joining us.
Thanks, Dr. Gibson.
And thanks to all of you out there joining us here from SCAI 2017.